Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha from Roots Community Health Center reporting for the week of November 29th, 2021. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to keep yourself, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Today I am going to skip case and hospitalization and death updates because it seems that over the long weekend many of the sources that I pull from were not fully updated, so we will save that for next week. But in brief, here in Alameda County, we are still continuing in a plateau. Don't see signs of an uptick yet, but again, don't have the most recent days having been updated yet either. So I will go right into updates, and I don't have the greatest news to share today, but it is the news nonetheless. So first off is some updated data from Merck. You might recall back in October that Merck submitted for emergency use authorization request to the FDA, and this is for this pill, molnupiravir, and it is a antiviral that I'm not going to go into a lot of detail on today because it is actually being taken up by the FDA as we speak. And if it is granted emergency use authorization today, it will be the first antiviral pill that treats COVID-19, and it is for mild to moderate COVID-19 for adults, and it's particularly for those at risk of severe disease or hospitalization. And so the not so great news is that the original estimates from Merck was a 50% reduction in hospitalization and death. But now that they have data for a much larger sample size, about double sample size, they have updated those results, and now it is looking like a 30% reduction in hospitalization and death. So this is definitely not quite as hopeful of news. And we know that the only outpatient treatment we currently have is monoclonal antibody treatment. That is an outpatient treatment, but it is an infusion treatment. So it's not the most convenient thing in the world, but it is free and it is accessible, and it is reducing the risk of death and hospitalization by 70%. So far more effective, and it brings into question whether this treatment, this oral treatment, will in fact be granted the emergency use, because we seem to have another treatment that's much more effective. But of course, a pill would be so much more convenient. And when people are diagnosed after hours or on the weekend, they can get a prescription and go pick it up. And so we've definitely been wanting to see this happen, wanting to ensure that all of our community has access to this treatment. But unfortunately, the results are just not quite as dazzling as we had originally hoped. What is on the horizon is the oral by Pfizer. We don't know when that is going to be taken up by the FDA, and we have not seen those results yet. So more to come on this, and we'll actually know more likely later on today. Now, the other update, which is not a very happy update, but we will just walk our way through what we know, what we don't know, and what we need to do. So over the weekend, while most of us were hopefully enjoying time with family and maybe some turkey dinner, there were scientists all over the world working away on what was discovered as a new variant. And on the 28th, the World Health Organization declared that this variant is a variant of concern. And the variant is called Omicron. I will get to that in a second. But it was named as a variant of concern because it has a number of mutations, that there is certainly a concern that it may escape some of our immune response, either from the vaccine or from prior infection or both. And there was also a concern that the likelihood of spread across the globe was high, or is high, and that based on some of the characteristics that were noticed, that there could be surges of COVID-19 in the future across the world with severe consequences. And so as a result, the World Health Organization declared that the risk is very high of Omicron as a variant of concern. And there's a number of criteria that have to be met for a variant to be named a variant of concern. Some people are debating a bit about whether this truly met the definition or whether we were erring too far on the side of caution. But I think that the consensus so far is that it is much easier to err on the side of caution and dial it back later if things turn out to not be so concerning, than to not react and then find that we don't have a robust enough response. So as it stands now, this variant, which is B11529, has been determined a variant of concern by the World Health Organization, and this is a technical advisory briefing from the World Health Organization, and it details over about 8 pages all of the background as well as what the priority actions should be for all of the world, essentially. And the variant was given the name Omicron, and it now is the 5th variant of concern that is currently named by the World Health Organization. The others are Alpha, Beta, Gamma, and Delta. There's a whole bunch of other alphabets in between there that were identified variants, but that were not of concern. And there are 2 of interest, which is kind of the next level down, and those are Lambda and Mu. We were pretty concerned actually about those when we first saw those variants, because they also looked like they might be evading the immune system, but they just could not compete with Delta. They were just not as contagious, and Delta took over. And so sometimes we see things in the lab that give us concern, but then in the real world, we can't really predict what's going to happen, and sometimes we have to wait and see. So there's still a lot left to wait and see. So as it stands now, the CDC has not declared it a variant of concern. Now, with Delta, they waited quite some time after the WHO declared it a variant of concern. So we're just going to be keeping an eye to see what it is that the CDC is going to declare. But right now, we don't know if it is here in the United States or not. We will certainly be learning more in the days and weeks to come. And so, just very brief overview about mutations in general. I think, first of all, it's fair to say that no one is surprised by another variant of concern, or nobody should be surprised. We have very uneven vaccination rates across the world. There's still quite a bit of transmission, and we fully expect to see mutations that cause variants. We just never really know when they're going to happen or how important they're going to be. In fact, most mutations are irrelevant. They have no impact at all. But with the volume of replications, something's bound to stick, and in this case it has. And you recall that mutations are basically just mistakes, and these are mistakes that happen spontaneously as the virus replicates itself. Viruses mutate, that is what they do. It is not a conspiracy. This is what viruses do. It would be weird if it didn't mutate, actually. And so with all of the replications that it's undergoing, it is making mistakes sometimes that don't get corrected, even though there are mechanisms within SARS-CoV-2 to actually enzymes that go back and correct. But some of the mistakes actually don't get corrected, and some of those mistakes make the virus more efficient in one way or another. It might be more efficient at spreading, might be more efficient at latching onto our receptors, it might make it better at entering into ourselves. And then there are different pressures that get placed on the virus that can actually help create the conditions for this to happen. I went over these in a lot of detail in the February 2nd, 2021 briefing, a lot of detail about mutations, but quickly, there are a couple of main ways that we see this kind of happening with COVID-19. The first one that we're familiar with is actually human to animal and animal to human transmission, or just crossing different species. That is one way. The other, and what many experts now believe happened with Omicron variant, is that mutations can actually happen inside of an individual, a person who has a prolonged course of COVID. So, for example, a person with immune compromise, let's say someone who is on chemotherapy, if they catch SARS-CoV-2, they can end up infected with COVID for weeks or even longer, a prolonged or chronic infectious course of COVID. And during that time, the virus can actually replicate and mutate inside of that individual, and then that individual can spread it. And this is what is believed to have happened, though it's not conclusive with Omicron. So, more on Omicron specifically. The name certainly sounds a bit ominous. The reason why we ended up here is because, as I mentioned, there's a number that have already taken up other Greek alphabet letters, and some of them aren't variants of concern, so you haven't heard a lot about them. The last one was Mu. It's still named a variant of interest, and then the next ones after that were supposed to be new, but everyone thought that that was just going to be confusing to be a new variant. And then the other one is spelled XI, the next letter, and because that is a common name and a name of a leader in China, that was also skipped. And so the next one in line was Omicron, so that's what we're working with. And it was identified in South Africa, and I think we all owe a debt of gratitude to South Africa for their continued vigilance. Remember, South Africa has a number of scientists, virologists in particular, and quite advanced sequencing. They are doing the majority of sequencing on the continent, and they are adding capacity for a number of other countries in Africa to do more sequencing. They have advanced quite a bit of research and development in HIV and other viruses. And so they certainly do have quite a bit of capability in sequencing. And I think we owe them a debt of gratitude for being transparent, even though they, I'm sure, were concerned about blame and stigma, because we've seen that time and time again. And I think we all can recall with HIV kind of blame and stigma being placed on. But it is concerning that there has been some very knee-jerk reaction around banning travel from South Africa, as well as other countries in the southern part of the continent, even though Omicron has been detected in over a dozen countries now. These include not only South Africa and Botswana, but the Netherlands, Australia, Hong Kong, Italy, the UK, Canada, Germany, Belgium, Israel, Spain. I could go on. And so I think I'll talk a little bit about the travel ban in a moment, or the travel restrictions in a moment. But as of this moment, or actually as of Monday evening, there were 172 cases of Omicron detected or sequenced so far. And 172 is, of course, a very small number. We've had over 250 million cases worldwide. And so we just cannot do a whole lot of comparing about what we are seeing clinically. We can't really do a lot of comparing between what we're seeing with Omicron and Delta, or any of the other variants for that matter, because the number is tiny. So really a lot of the action is being taken not based on what we're seeing clinically, but what we are seeing in the lab and a few other components that I'll get to in just a second. And so why are we concerned? So Omicron, as I mentioned, has some concerning mutations. It actually has more than 30 mutations on the spike protein. So this is concerning because the spike protein is that kind of key to the lock on our cells. It's how SARS-CoV-2 is accessing our cells. And so mutations on the spike protein are concerning because, first of all, could it allow SARS-CoV-2 to enter our cells more readily somehow? Remember, we were very concerned when Delta came out and it had 8 mutations on the spike protein. And we saw it very quickly outcompete all the other variants all over the world, and now it is dominant over the world. So this obviously is giving rise to concerns that there's more than 30 mutations on the spike protein. But the truth is we don't really know how these are going to play out. Sometimes mutations, like I mentioned, don't do anything. Sometimes they can even kind of cancel each other out. But definitely we are concerned because our immune response is also largely to the spike protein. And so, whether it is from vaccines or infection acquired immunity, a lot of our antibody response in particular is against parts of the spike protein. So, if it has mutated and evolved too far away from what it was when we acquired immunity, either through infection or through the vaccine, then the concern is that our immune system will no longer recognize it. And so, again, this is remaining in the realm of theoretical for the moment because we don't yet have the tests. These are tests that we anticipate having within days, maybe a week, 2 weeks at the most, to be able to see what is happening in the lab. So, to be able to check antibodies that might exist within a person against this variant and see if it's able to be neutralized and see if there's actually if it's actually evading our response or not. Now, the next reason why we're concerned is because there appears to be a rapid increase of Omicron in some areas of South Africa. And we've all probably seen graphs over the weekend, which I'm not going to show, and I'll tell you why, that show this just very rapid increase of Omicron. And it is making us concerned that it is going to overtake everything. But I think because the numbers are so small, and there's a few factors which may be confusing the picture, I think it is premature to be looking at it that way. We saw it happen with Delta, so of course we're on alert and we're concerned. But at the time when Delta came out, we were also still dealing with very, very high rates of the other variants that were before it, and we saw it out competing. But this time, it's a different situation because overall, the area of South Africa that we're talking about has had low case rates. And so, with low case rates, it makes it hard to tell if Omicron is truly outcompeting Delta, or is it really kind of the only game in town? And so, therefore, it just looks like it is taking over. And that's something that's called the founder effect. And so, if it's kind of the only game in town, then of course it's going to increase quickly because there's nothing competing with it or nothing substantial competing with it. And so, that could be what is happening. The other thing that's happened is that, according to a media statement that came out of the South African Health Department, and this came out on Tuesday, November 23rd, they added antigen tests on the line list of their COVID-19 statistics. So the antigen tests, remember, are the rapid tests. And so through their outbreak reporting system, they added these tests and they kind of added them in big bulk, so thousands of them. And they even said on November 23rd, so before we even knew about Omicron, they said that you will observe an increase in single day cases, and that is going to create distortions of the 7-day moving average, which is what we often look at, and that it will create an unusual looking spike. So all of that was actually stated ahead of time. And so could that be part of it? It's hard to say. But I think, again, we don't want to jump to premature conclusions about it displacing anything else because there's a few different factors at play. And with that tiny number that I mentioned of less than 200 cases, it's also too soon to be drawing conclusions about the severity. It's too soon to be drawing conclusions about what is happening in vaccinated or unvaccinated. So what we're hearing is a lot of anecdotal reports, which are fine. We should hear the anecdotal reports. At least the anecdotal reports are not sounding terrifying. They're sounding, if anything, they may sound reassuring. But I would kind of caution us about being either terrified or reassured about anything yet because the numbers are just simply too small. And in fact, some of the early outbreaks were within schools or universities, young people who tend to do better with SARS-CoV-2 anyway. And so, again, not a representative sample. We will just need to see what happens as time goes on. So that really sums up why we're concerned, both what we're seeing in terms of the mutations as well as how it seems to be behaving in South Africa, which now at this point has identified the most cases. We don't know if that's where they started. we really don't even know when they started, because remember, hospitalizations lag behind cases by a couple of weeks. So it really is possible that this started back in October. We don't know. We will find out, but right now we just don't know for sure. And so right now we are trying to gather more evidence, and I'm going to now talk about what the good news part is. First of all, I think the good news is that it is very unlikely that our immune response to SARS-CoV-2, whether it was from the vaccine or from past infection, will be completely just useless or will be completely evaded by Omicron. And this is because our immune response, both from vaccine and from infection acquired immunity, is a very diverse response. It is actually a little bit nimble, so that when you get presented with the real thing, you can adapt. Your immune system can adapt. And I went over in great detail on October 5th, 2021, a review of our immune response. And so if you're interested in taking a look at that, please do, because it kind of explains why, for instance, we didn't need a new vaccine when Delta came out. Remember, the vaccine was created against kind of two mutations before that. And we didn't need a new vaccine because the response that we mounted was still good enough, essentially, good enough to still protect us from hospitalization and death. And so that is, of course, the hope. We don't know. We're concerned because of the number of mutations again, but it's unlikely that it just won't be effective at all. Could it be that the vaccines or the infection-acquired immunity is less of coverage, is less protective? Yes, that is definitely possible, and that is something that scientists will be looking to quantify over the coming weeks and months. The other good news, and this is significantly good news, is that our PCR tests still detect Omicron. So, of course, this would be a bad scenario if our PCR tests did not detect this variant, because we would be having to retool a whole lot of infrastructure that we have to be able to detect SARS-CoV-2. So it's good news, and even better than the fact that it can detect it, there's actually sort of a feature of what happens when you get a PCR test that tells us actually if it is more likely to be Omicron, and that is called a S gene target failure. And without getting into a lot of detail, it's basically one of our most widely used PCR tests. Will basically have this kind of a dropout where one of the gene targets doesn't get picked up. So it's kind of like a proxy or a marker. If that happens, then we're going to think, oh, this might be Omicron, because this happens with one of the prior variants of concern with the alpha variant, which we don't have a lot of going on right now, but it doesn't happen with Delta. And so basically this would be kind of a marker or a way for us to right away with the PCR test kind of suspect that it could be Omicron, and then we can go back and actually do the full sequence. So it's kind of like we're going to presume that it is Omicron until we do the full genomic sequencing. And so this is actually a big advantage, in a sense that not only does our PCR test continue to pick up Omicron, but also there's a way for us to tell quickly if it might be Omicron. And this is something that actually it appears that maybe in South Africa they began to do the same thing. So they basically said, okay, if we have this feature on the PCR test, then we're going to do the full sequence. And so that can give us a bias as well, because if we start just focusing on those, then it might make it look like, oh, we're sequencing way more Omicron than Delta, but it might be because that's what we're choosing to do, which is understandable, but this has to be taken as part of the big picture as well. And so we do have the tools to find it, and that is good news. And the last piece of good news is that all of our non-pharmacological interventions will still work. Omicron is airborne, Delta is airborne, all SARS-CoV-2 is airborne. And so all of the precautions that we've been taking, our masking, our improving indoor ventilation and filtration, our reducing indoor occupancy, all of those things will still work to reduce transmission, Omicron, Delta, or otherwise. Now, on to what we still don't know. We do not know how contagious it is. We are concerned because we're hearing anecdotal reports now of people who are vaccinated, catching it and passing it on to someone else who is vaccinated. And we don't see that happen a lot with Delta. We know it can happen, certainly. So again, these are all just anecdotal reports, but what we need to know is how contagious is it? And that will be able to be quantified soon. And if it is more contagious, we need to know why. So is there something about Omicron with its mutations that is making it easier to transmit? So maybe the viral load is so much higher in the nose and makes you sneeze more. So I'm just totally making stuff up, but I'm just giving an example. Is there something about Omicron itself that makes it more contagious? Or is it more contagious because it is evading our immune response? So people who are vaccinated are not protected and then they're able to spread it more because of that, or both. So there's a lot to unpack there. Even if we find out it is more contagious, and we need to find out why. The second thing we don't know, is it more virulent? Is it going to make you more sick? We don't know the answer to that yet. But that is something that we will need to be watching clinically. And again, is it something inherently about Omicron, or is it because it is evading the immune system? And then how well do vaccines protect against infection? How well do vaccines protect against transmission, against severe illness, and against death? And this is what we will be evaluating both in the lab but also in the real world. And I think we'll start to just get information. And unfortunately, it's going to continue to probably be piecemeal a little bit. And so we are going to have to do what we can to just remain calm and wait for the information in general, what to do. So what to do, and I'm going to talk about kind of big picture what to do. So first off, I do appreciate the World Health Organization for moving quickly to name Omicron a variant of concern. Even though I'm sure that there was concerns that maybe it was being done before having all the information we would want to have. I think we've hopefully grown a little bit accustomed to having to make decisions with imperfect information during this pandemic. We know that there's a desire not to create a panic, but I also think that there has been a bit of a pattern during this pandemic of perhaps not wanting to create a panic, not being as open and transparent as we could, and then that creating more mistrust. And I want to say that this was refreshing in the sense that South Africa was open and transparent, even at detriment to itself, now being sanctioned essentially, or really being harmed by travel advisories that are probably unlikely to be very effective, but still they did the right thing. And I think also the World Health Organization should be commended for wanting to take swift action, because what happens when it gets named a variant of concern is that we go into action, and they make a call to action on a number of different fronts. And I'll talk about that in just a moment. I think it still remains to be seen, like I mentioned, whether the CDC will follow suit. But hopefully, all of the labs and other public health departments and entities that do sequencing are going to be able to start identifying it. And even if the CDC has not declared it as a variant of concern, we're certainly hopeful that it will still be getting reported through the channels that the World Health Organization is requesting, so that we can know if and when it does hit the United States, and whether we need to be concerned. Now, a note on these travel restrictions. So maybe travel restrictions might slow things down a little bit, but I think the way that they are being implemented and being selective against certain countries is simply not effective, and it's a little bit questionable, frankly, because there are actually a couple of countries like Morocco and Israel who have done a complete shutting down of their borders. And if you're going to do it, that's probably how you got to do it. If you're really doing it because you want to stop it from coming in your country, then you've got to stop travel from everywhere, because the train has already left the station, so to speak. There's no way that banning travel from 8 countries in Southern Africa is going to stop it. And I think that this should be discouraged, frankly, because what I worry about is that is going to make countries, especially poorer countries, that cannot afford to have these kind of sanctions being placed on it, that they won't be so motivated to disclose if they've got variants, or maybe they won't even be motivated to sequence them in the first place. So we are all in this together. We are going to have to see our way out of this together. And I think that we have to be more evidence-based in how we are applying interventions. And a selective travel restriction is not evidence-based, and it may do more harm than good. Now, another thing that we are going to do about it, that we want to do about it, is we have to wait and see what the data says about whether it is evading our response to the vaccine. We expect to have that information, like I said, in another week or two. Pfizer and Moderna have already laid out plans of what to do if this happens. And they are saying that they could have updated vaccines within 3 to 4 months, actually updated, approved, and manufactured. Essentially, the stage that we are in, they would have to have a smaller sample size in their trial. And the duration is shorter because it's really considered as a vaccine update. Because remember, particularly with the mRNA platform, it's kind of a plug and play situation where we've got the new sequence and they can go ahead and update it. And I think the hope is that we're not going to have to do this. This is kind of a worst case scenario situation that we have to actually update all of our vaccines and all get vaccinated again. I know none of us wants to see this be the way. But if we have a worst case scenario, hopefully 3 to 4 months isn't going to be too long or too late. And so that is why, all of the non-pharmacologic interventions like the masks and filtration and ventilation, all of those things become even that much more important right now. The other thing we can do about it, as I mentioned, it is reassuring that our PCR tests can detect Omicron. But it's concerning that we are still, as a nation, sequencing so few of our specimens. As of just a few months ago, I took a close look, and the UK was sequencing more than 10% of their specimens, Australia sequencing 60% of their specimens, and the US only 1.7% of our specimens. And the World Health Organization has actually set a goal for countries of at least 5% and preferably 10% genomic sequencing so that we can identify things like this sooner. And I think, given the fact that the United States has contributed such a big portion of cases to the overall cases, we've got almost 20% of the cases can be attributed to the United States. And given our relative wealth, I really think that we have got to do better. And I think we have got to raise the bar in terms of the percentage of samples that we are sequencing. Here in California, we are certainly doing much better. And my understanding is that we are somewhere between that 5 to 10%. So that is good news. And we can be looking to our state to be also updating in terms of sequencing efforts. And the last thing I'll note about that is that the World Health Organization has called on all of the member states as a priority to not only sequence anything with that S gene failure, target failure that I mentioned, where it's kind of that early proxy for Omicron. So not only going forward, but also to go back. So the World Health Organization would like to see countries go back to October and retrospectively analyze specimens, because the concern is that has been around at least since then, and this is going to help us better quantify things. And so we'll be looking forward to seeing who takes that up and what it is that we discover. And so, if it was up to me at this point, if I was in charge, what would we do? I think we would really double down on all of our efforts, particularly those non-pharmacological efforts. I think we would step up our mask game. We would distribute free N95s for everyone. I know N95s are not that comfortable, but I would encourage all of us, if you are around the public, if you are mixing, if you are planning on traveling, certainly an N95 or a legit KN95 is the way to go, because I think it is time to step up our masks and not just assume that they're all created equal. They really are not. And while surgical masks and cloth masks might be just fine if you are, outside milling around with other folks, because it will protect you from the droplets that we're concerned about outside, but they are not going to do the job as it relates to aerosol transmission, which is the main thing that we are worried about inside. So if it was up to me, everyone would have free N95s for everyone, and we would have paid COVID sick leave for everyone. We would have free rapid tests for everyone. And we know the White House has said that they've made an investment in rapid tests. I would like to see that hit the streets and be in everyone's household. We would have global vaccine equity. As long as we have such uneven coverage with the vaccines, we are always going to be, well, I shouldn't say always, but we are likely to continue to face this situation of variants of concern. And we are, as I said, we're all in this together. So if we can have manufacturing going on in other parts of the world, if we can do a better job of sharing and not hoarding vaccines or intellectual property for that matter, then I think that we can go further towards getting ourselves out of this. We would also do a better job at finding the source whenever there's an outbreak. And I think that we should all be very vigilant and mindful if you catch COVID, really trying to figure out where and contact tracing from there. And so that's why I always talk about having sign-ins at indoor gatherings. If it was up to me, we have them at all indoor gatherings like restaurants and concerts and so forth, so that if and when someone is positive, you can very easily contact everyone, you can get to the source, and you can contact trace. We would also have ventilation mandates for schools and for venues, because all venues and all spaces are not created equally, and ventilation makes an enormous difference in terms of preventing the spread of COVID-19. We would increase our genomic sequencing efforts in the United States and worldwide. And instead of travel restrictions, we would just do a better job of making sure that we are not importing and exporting variants. So after travel, we would be testing, we would be doing PCR, we would be doing quarantine, we would be doing follow-up testing. This is how we can potentially do a better job of stopping the spread of variants rather than these spotty and sporadic, without rhyme or reason, travel restrictions. So, bottom line on Omicron, yes, there is reason for concern based on the number of mutations and what looks like a potential rapid spread, but there is so much that we still do not know. It's even possible that this strain is less deadly. It's possible that our vaccines work just as well against it. But that's not necessarily the case, and we still need to wait and see. And we need more time to answer all of the questions that I mentioned earlier. But I will say, and I do feel confident in saying, we are not back to 2020. I've been hearing a lot of people say that. It feels that way, and I get it. But we are absolutely not back to 2020. We have a number of tools, we have a lot more knowledge. We have the ability to quickly produce vaccines if needed, hopefully not needed. And we have the knowledge and the know-how. I think though we really must be thinking globally about the knowledge and the tools, and we must think about how to implement them worldwide so that we can see our way out of this pandemic. And in the meantime, the actions to take now: vaccinate the unvaccinated, boost those at risk. If you are due for your booster, or if you are not vaccinated, now is really the time. You want to get fully vaccinated in the event that this thing does hit us. But even if it doesn't, because remember, we were already anticipating a Delta surge over the winter, and that has not changed. So it could be worse with Omicron, or it can be what we thought. But either way, this is not the time to be going without antibodies. We want to embrace doing things outdoors. We want to make our indoors safer. We want to test strategically. And at this point, particularly with the new variant out here, I really want to say have a very low index of suspicion with your symptoms. If you've got a headache, go on and get tested. Sore throat, runny nose, go on and get tested. Of course, we know losing taste and smell is very particular to COVID-19, but there are a number of other things that may look like a cold, and we want you to get tested quickly because then you can prevent spread, but also you can get access to timely treatment and it may save your life. And isolate, and we want to contact trace and treat timely. Wear a high quality, so go ahead and invest in some higher quality, high filtration, properly fitting masks. If you test positive, and especially if you're in a high risk category, whether you're vaccinated or not, please inquire about monoclonal antibody treatment. And for everybody, eat a well balanced diet, get some exercise, take a multivitamin supplement, and consider additional vitamin D. Manage your stress and get a good night's sleep. Thank you for joining us. Hope to see you next Tuesday at 10. See you then.